This is Salah Al-Hamamsi, Assistant Professor in Brown University. I would like to talk and share my experience about the psychological impact that COVID-19 had on healthcare professionals in the United States. I want to first start talking about the case that I worked with in April. The patient came to the hospital with shortness of breath, fever, cough, nausea, vomiting, and abdominal pain and body aches, which are the symptoms that can be associated with COVID-19. The patient's blood work showed an elevated ferritin, abnormal liver function tests, and an elevated D-dimer, slightly low platelets, and a low absolute lymphocytic count. The patient was admitted. We did a SARS-CoV-2 swab. We got a 12-lead EKG to check on the QTC interval and the chest X-ray that showed bilateral opacity. The patient reported exposure to family members who had COVID-19. So based on that, we presumed the diagnosis of COVID-19. The patient was treated with the protocol at the time that included hydroxychloroquine and azithromycin, admitted to telemetry. When the patient presented to the hospital, he was on room air. By the time he arrived to the floor, the patient was requiring 3 liters of oxygen to set 93%. That was on day 1 of admission. A CT scan was obtained of the chest, CT angiogram to rule out pulmonary embolism. The CT scan showed evidence of COVID-19, bilateral patchy opacity, and densities at the lung base. This is the CT scan from April. At the time on April 3rd, when the patient came to the hospital, he received Actembra and was admitted, was transferred to the intensive care unit due to rapidly progressing respiratory failure. This patient was intubated on the day of admission. The patient had an ICU course complicated by cardiac injury, a non-ST elevation, myocardial infarction, severe lung injury, liver injury and kidney injury, sepsis, septic shock, and ventilator-associated pneumonia. Stayed in the ICU for around 8 days, was extubated, and then transferred to the step-down unit. By this time, the patient was confused, hallucinating, in urine retention, having a Foley catheter that we could not remove, and the patient was hypoxemic on high-flow oxygen. The patient then developed abdominal pain on day 12 of his hospitalization with a drop in hemoglobin. We got a CT scan of the abdomen and diagnosed the patient with a retroperitoneal bleed. The reason I'm sharing this case is to give people like some insight on the complexity of these COVID patients. At the time we were anticoagulating these patients, we still do based on their D-dimer and the severity of the infection, because we know that COVID can cause a hypercoagulable state. My patient got a retroperitoneal bleed. He was a Jehovah's Witness, could not get a blood transfusion. The hemoglobin continued to drop until it reached 6.5 and then stabilized and then became 6.8 on day 14 of the hospital admission. Of course, we had to stop the anticoagulation and the patient ended up developing a bilateral DVT. The good thing is that this patient lived after nearly 15 days in the hospital, and we were able to discharge the patient, but the patient was confused, delirious, he didn't know where he is. He had blood clots in his legs, he had a bleed. So it was a very complicated situation. And at the time when we were dealing with these patients, we would be carrying 5 to 8 of these patients a day. We had to wear all the personal protective equipments, and we were really afraid. So I wanted to talk about the psychological impact of COVID-19 on healthcare workers. There's a paper in China that was based on a web survey done in February 2020, early on in the pandemic, to show the impact of COVID-19 on healthcare workers. The study used the Generalized Anxiety Scale, GAD-7, the Chinese version, used the PHQ-9 that we use here in the United States, and the Insomnia Severity Index to screen healthcare workers for different symptoms of anxiety, depression, and insomnia. In the study, 30% were men and 70% were women, and the average age of the healthcare workers was 61 years old. They surveyed 2,285 healthcare workers from different provinces in China. The study showed that amongst the healthcare workers, which included physicians, nurses, residents, and technicians, that 46% had anxiety, 44% had symptoms of depression, and 28% had symptoms of insomnia. 56% of the healthcare workers were having some psychological symptom being reported. Physicians who showed psychological distress included 60% of physicians, 50% of residents, 62% of nurses, and 57% of technicians. The frontline workers were defined as people who were directly in contact with patients with COVID-19, were more likely to develop symptoms of anxiety, insomnia, and overall psychological problems than people who were not directly in contact with patients having COVID-19. According to the CDC website, as of July 2020, 641 healthcare workers in the United States died from COVID-19, and 100,000 people were diagnosed by COVID-19. We all remember the story of the ER physician in New York who was treating patients with COVID-19, ended up getting COVID-19 herself, and then later on we lost her for suicide after she went back to work and then left work and then ended up committing suicide. So I wanted to share some of my personal experience when I was taking care of COVID-19 patients and directly in contact with these patients. I remember having nightmares. So I dreamt one time that I was in a room alone, I was confused and sick, and that my heart started beating irregularly. I had ventricular tachycardia and I started losing consciousness, and that the nurse was standing on the door and would not come and do CPR on me. And then I passed out in the dream. Another time I dreamt that I was at home and in a different room there was a friend, and I felt very dizzy. I started to pull my arm for my friend, and then I passed out and fell on the floor. So I had multiple nightmares when I was taking care and directly in contact with these patients in April and May. Also, I used to have chest pains and used to have subjective fevers and take my temperature every day. So from my own personal experience, I did have a lot of symptoms that showed psychological distress when I was in direct contact with patients with COVID-19. I did a Google search to see how many people are looking at things like I dream about COVID-19, and in less than 1 second, there was nearly 900 million results. I did another Google search saying I dream about dying alone of COVID-19, and there was 86 million results in less than 1 second. I remember one of my friends who was a nurse who got COVID-19, and she told me that she was taking care of a patient who was dying, and families could not visit these patients, and the patient was dying alone. And he asked her to stay with him and hold his hand, and she stayed for hours by the patient's side holding his hands, and she ended up getting COVID-19 infection, and probably from that patient. So I looked at another paper about the psychological impact of the SARS epidemic on hospital workers in China several years after the SARS, which is the old coronavirus that happened several years back. And this paper was saying that even several years after the epidemic ended, 10% of hospital workers who took care of these patients were showing signs of post-traumatic stress disorder. And we can clearly conclude that we will be having to deal with post-traumatic stress disorders that reminds us of what happened in wars, that we had to deal with post-traumatic stress disorder that outlived the duration of the war, and we will have to deal with post-traumatic stress disorder on people who took care of patients with COVID-19. Thank you.